Dr. Litt, thank you very much for your opening plenary talk. You mentioned some amazing new developments in the last year related to MRI for patients with cardiac devices. Tell us how you think that will impact on policy, but also what we should all be doing to change or potentially change the impact in this field.
Well, the publication this year of the MagnaSafe registry and then another large series of device patients from Johns Hopkins really provided evidence of what I think a lot of us have felt all along, which is that in most cases, patients with non-conditional devices can be scanned with an acceptable safety range. Of course, the proposals by the Center for Medicare and Medicaid Services in the United States aren't completely straightforward. They put some twists in them and some limitations which may or may not be reasonable, including a limitation that one cannot scan patients who are pacemaker dependent, a waiting period after placement of the device. But I think one of the things that they proposed is very useful, and that's implementation of a checklist system for organizing a program for imaging of patients with devices. I think the effect that this may have is that many centers will consider scanning these patients that haven't before, but they'll need to look very seriously at what resources are required for them to do it. It requires a tremendous amount of collaboration between imagers and electrophysiologists to set up the program appropriately, make sure that all of the information that one needs is available. For example, what kind of device does the patient have? Are they pacemaker dependent? This is not always a yes or no answer. One of the things that I've figured out is that pacemaker dependence depends upon the circumstances under which you're imaging the patient. So institutions will have to figure out a way to get the information and make these sorts of decisions. Can the patient who has a supposedly MR conditional device be scanned according to the parameters under which the device was approved as conditional, or will they have to be done as a non-conditional device? I think all of these things are important questions for sites to ask themselves. Are they going to be willing to dedicate the resources necessary, including someone to gather all this information, someone from electrophysiology to do the device programming, someone to monitor the patient during the scan, and someone to provide the appropriate level of follow-up? I think, in my estimation, that not every institution necessarily needs to have a program for imaging a patient's devices, and particularly in environments where there's a more centralized healthcare system, that it may be appropriate to have centers of excellence devoted to this. Probably every hospital is going to have to know how to do them because they'll have inpatients and emergencies, stroke patients, for example, who will need to be imaged. But not every place is going to need to have a full-fledged program that's imaging outpatients, for example.
Thank you very much. Just to follow up, you've mentioned a number of barriers to any centre who wants to do this to actually get a service in place. How can societies like SCMR help with that?
Well, I think SCMR can help by instituting some best practices, by making materials available on their website, how we did it, how you can start a program for imaging of non-conditional devices at your institution, and providing support for that training. A lot of the training right now for conditional devices is coming from the vendors of those devices. You have to go on their website and do their particular training. But SCMR is certainly in a position to provide more vendor-neutral training, both on the device side as well as the MR acquisition protocol side. Now, most patients with devices are not going to have cardiac MRs. Neuro applications are by far the most frequent. But you need to think about, understand concepts like normal level SAR, first level SAR, how the protocols need to be tweaked. And that's something where I think SCMR as a society that represents both radiologists and cardiologists can really bring those two groups together and provide educational content and support.
Thank you. And so, as a cardiologist myself, or as a radiologist, if I've got a waiting list now of patients with devices who need MRIs, what's the first thing I should be doing? Should I be looking to my collaborators in other departments, or should I be looking at funding bodies? Or how would you suggest taking that first step?
I think the first step in building a program is to get all of the stakeholders together in one place. And that certainly means radiologists, electrophysiologists, but also hospital administrators who are going to need to provide the resources necessary or the funding for those resources. And if you're in a healthcare system where that comes from a central governmental authority, then that authority needs to be engaged and plan for it on a more widespread scale than just a single institution.
Thank you very much.
You're welcome.